Placing a TE probe requires skill, precision, and at times some advanced maneuvers. In this episode of Tea Time, we'll break down a process that helps ensure a safer and more successful TE probe insertion every time. Welcome to episode 4 of Tea Time, where we talk about proper TE probe insertion and troubleshooting a difficult insertion. The clinical question we'll look at today is how can we safely insert a TE probe, and what options are available for troubleshooting difficult TE probe insertion? Up to this point, we've talked about when to use TE, when not to use TE, and now that we're at a point of using it, let's talk about how to safely insert the TE probe for your case. This is TEE probe insertion under general anesthesia, not under sedation. So the patient will have an endotracheal tube, and we'll talk about the process for a patient under general anesthesia. So when you're placing the TEE probe, anatomically, there's really only three major places the probe can go. It can go in the intended target in the esophagus, it can go in an unintended target like the trachea, or it can cause a soft tissue injury and very commonly in the piriform fossa. So when you are troubleshooting a difficult insertion, it's important to remember you're in one of three places most of the time, and it's these three that you want to think about. So we're going to walk through the steps of proper TE probe insertion from before you start to after you finish. Let's start with what to know and what to do even before you start inserting the probe. Prior to insertion, it's important to rule out that there's any prior TE probe damage. This can go undetected during the re-sterilization phase. Next, double check the wheel to make sure it's in the unlocked position. There's three positions it can be in. One, in the unlocked position, push all the way to the left when you're looking at the wheels. It can be in the center position, and the center position means the small wheel is locked and the large wheel is unlocked. Or it can be in the rightward position where both wheels are locked. It's safest to have it in the unlocked position when you're ready to place the probe. Another thing you want to have before insertion is a bite block. I use this anytime a patient has teeth, and it's recommended to use even under general anesthesia as it can help protect the patient's teeth and the probe from damage. Don't place this bite block in the mouth before you place the probe, as that can make the tongue fall back posteriorly. Keep it slid up the TE probe, place the probe, and at the end, we'll slide down the bite block into the correct position. It's also important to have the probe secured on a stable source prior to insertion, as this will allow both hands for TE placement, which makes the process much easier. A couple other quick notes. Please use gloves. This really does go without saying. And make sure you take off your gloves before you start touching your TE machine to avoid contamination. Also, let's make sure the patient is adequately anesthetized and paralyzed before we place the TE probe. Unfortunately, I've seen this two times before where a patient was induced with succinylcholine. Hands were stuck in the mouth to place the TE probe, and the provider was bit by a patient who wasn't adequately anesthetized and paralyzed. Luckily, I still have all 10 fingers. It hasn't happened to me, but just one quick check. Make sure you've given your paralytic when you're placing the probe. Also, as far as neck positioning, the sniffing position really is ideal. The same position you would use for intubation is most ideal for TE probe placement. So the sniffing position can help you. Lastly, the probe tip position is important to have it slightly antiflexed and in the neutral position, not off to one side or the other. Let's talk about how we go about actually inserting the probe now. So when I'm placing a TE probe, I start at the head of the bed, facing the feet. Make sure you generously lubricate the TE probe. You can't overdo this part. Next, you're going to create space in the mouth and oropharynx by grabbing the lower teeth with your non-dominant hand and protruding the mandible anteriorly and slightly caudally. This will help displace the tongue and create a better path for your TE probe. A few alternatives to this are to have a second participant provide a jaw thrust. This will displace the tongue anteriorly just as well. Or you can very, very gently grab the trachea and slightly lift forward as this displaces the trachea anteriorly and slightly opens up the esophagus to be able to find the esophagus easier. Lastly, it's important to make sure your TE probe starts midline as to avoid going off to one side into the piriform fossa. Now, the grip you use when it comes to TE probe insertion should be a pincer grip with your dominant hand. We want to make sure we use a pincer grip here and not a fist because that is all you need to apply adequate pressure to place the probe. Using a fist can generate way too much force, which predisposes to esophageal or soft tissue injury. That's why using gentle pressure with the 2 to 3 finger rule, where you only need 2 or 3 fingers to safely place the probe, is important to remember. Also, at the 15 to 20 centimeter mark, you'll feel a slight give when you place the probe, and that's the probe going through the upper esophageal sphincter down the esophagus to confirm you're in the right location. Lastly, when you're at about 30 to 40 centimeters, you can stop and confirm you have a TE probe image, which indicates you're in the correct location. Obviously, it would be a very ominous sign if you don't have an image and there's no equipment failure, as this could indicate an esophageal rupture where you're outside the esophagus. This would be very rare, but something to be aware of. There's a few things to note after TE probe insertion as well. What helps me organize my space in a complex cardiac case is to have the endotracheal tube to the right and the TE probe to the left. This helps prevent inadvertent endotracheal tube dislodgement. Also, after the probe insertion, that's when you want to slide your bite block in place and keep it there for the remainder of the case. Finally, it's important to secure the TE probe in a reliable place. You can do this by hanging it on a stylet that's on an IV pole. You can use extra IV extension tubing to loop that and place it on an IV pole, or you can just place it around your neck and hang the TE probe that way if you're in a remote setting where there's no IV poles available. There's also commercially available devices that help hold the TE probe or secure it in place as well that you can purchase for your institution. Say the TE probe insertion is difficult. Let's talk about troubleshooting and what steps we can take to help improve a difficult TE probe insertion. I break up troubleshooting into two main categories: when you have difficulty at 15 to 20 centimeters or before, or after about 20 centimeters, as these indicate two very different pathologies that you may encounter. Let's start with troubleshooting when your TE probe depth is at 15 to 20 centimeters or less. The two main problems you can encounter with this are where your probe is not at the esophagus, where it's either in soft tissue or a trachea, or when you have pathology that you encounter at or above the upper esophageal sphincter. The first step I do when I troubleshoot this is I feel the patient's neck. At times, you'll feel the TE probe going off to one side or the other, and feeling the neck and where the probe is poking can actually help you redirect your probe at a better angle. Also, you can take 2 fingers and actually put them in the mouth to depress the tongue and give yourself a track to place the TE probe down directly towards the esophagus. Another maneuver, and you have to be careful when you do this, is to come in from the left side of the mouth instead of the midline and direct midline. Some patients have very large tongues, and doing this will help avoid the tongues that can commonly displace the TE probe to one side or the other. You have to be careful to avoid the piriform fossa in this maneuver, but it can be a trick that helps for difficult placements. Lastly, using a laryngoscope blade can definitely aid in a difficult placement. You can use a Miller 3 blade, place it down into the esophagus, which essentially gives you a track to place the TE probe and place the probe right away that way under direct visualization. Or you can use a video laryngoscope to be able to see close in the mouth where the TE probe may be getting hung up and give you some insight into how you can maneuver it differently. Now, if you're really stuck with TE probe placement, I'm going to say this a few times, but when in doubt, just call GI. They have equipment available and insight available that really can help guide you in difficult placements. I want to touch a little bit more on laryngoscope placement, particularly with video laryngoscopes. There was an article that came out a few years ago in the Journal of Cardiothoracic and Vascular Anesthesia that assessed if video laryngoscope could reduce the complications of TE probe insertion. The primary endpoint was assessing for oropharyngeal injury, and the secondary endpoint was assessing number of attempts until successful TE probe placement. Using a video laryngoscope for TE probe placement showed almost half the number of oropharyngeal injuries compared to the conventional group of using it without any laryngoscope. It also showed a significant difference in the number of attempts, being fewer in the video laryngoscope group as well. In summary, fewer injuries, fewer insertion attempts. It does beg the question, if you used a video laryngoscope to intubate, why not just use it again to improve TEE placement success? The other category of troubleshooting is when you're at a distance of 20 centimeters or greater and you encounter resistance at that point. This is a much more alarming problem, as I want you to think this is esophageal pathology until proven otherwise. There's a couple things that you can do very, very or you can rotate the probe slightly to see if it will pass through any abnormality. I think it's very, very important at this point, if you've tried 2 or 3 times without success, to consider calling GI for a consult and potential EGD. You really can cause patient harm if you continue aggressive attempts at insertion. Again, I went over this last episode as well. Do not continue with aggressive attempts at insertion. That is one of the major takeaways from this. That will get you into trouble. If you get to a point where you truly can't advance the TE probe safely, you do have other modalities available to you depending on the type of surgery. And this includes TTE, ICE, epicardial imaging, epiaortic imaging, or even using a pulmonary artery catheter for the case for more information. And as another reminder, call GI, have their number on speed dial, find someone you can call to run ideas by or to get extra help. Now, I do want to talk about one more alternative technique that could be used in a very difficult placement where a TEE probe is indicated. In a patient who had esophageal diverticulum and stenosis, this was one way to help manage that risk. Essentially, an ERCP guide wire was placed into the esophagus and down into the stomach using an EGD, and there was a small catheter that was taped to the back of a TE probe, as you can see in that lower picture. Now, after the wire was placed, it was threaded through the catheter that was on the back of the TE probe here. The probe was placed over the wire into the oropharynx and part of the esophagus. And you'll see the TE probe was initially directed towards the esophageal diverticulum. It was rotated and then it was advanced safely into the stenotic area of the esophagus. So there are alternative options available to you out there if you're creative, if you work together with good consultants. Just be smart, weigh the risks and benefits. Please be gentle. I've already said this a few times, but it's not about force, it's about finesse. When you remove the TE probe at the end, double check to make sure there's no blood at the probe tip. Make sure the endotracheal tube is well secured, as I have seen these dislodged when the TE probe was being maneuvered in and out of the patient mouth. Also, last time I'm going to say this, if you need help, call a gastroenterologist. They are invaluable in this process. All right, so we've talked about when to place a probe, when not to place a probe, how to place it. Now we need to do an exam. So, next episode, we're going to talk about the most efficient, most effective way to do a TE exam. I really appreciate you guys watching. If you want more of this content, hit the subscribe button, write a comment sharing your thoughts and your experience, and leave a review. That really does help us reach more people. We'll see you guys next time.